Good afternoon. I would like to thank Professor Juro Matsut for inviting me to talk about metabolic clustering to the phenotypes of adult PCOS. Polycystic ovary syndrome is the most common endocrinopathy in women in reproductive age, affecting from 6% to as much as 20% of this group, depending on the applied diagnostic criteria. The etiology of PCOS is multifactorial and is yet not completely known. However, it is clear that this syndrome is a result of complicated interplay between genetics and lifestyle. Hyperandrogenism and insulin resistance together induce various cardiometabolic disturbances, leading to increased CVD risk. Different studies have shown that after obesity, presence of PCOS or hyperandrogenism carries the greatest risk for cardiovascular diseases. Morgan and co-workers performed a study in 2012 which included 53,000 women. They showed that women with PCOS have 3 times higher risk for type 2 diabetes in comparison to healthy women. Also, women with PCOS had higher overall mortality. So what is the reason for so high cardiometabolic risk in women with PCOS? Namely, each of these factors carry a risk for cardiovascular diseases. Among majority of PCOS women, several of those factors are present at the same time, carrying a greater risk for CVD than healthy population. When several metabolic disturbances are present at the same time, we call it metabolic syndrome. It is well known that it affects nearly 50% of women with PCOS. One of the most significant events in the field of PCOS was when Rotterdam criteria were introduced. The main reason I say that is because, being more flexible, these criteria enabled clinicians to analyze PCOS in more, let's say, ordered way. Thanks to Rotterdam definition, combining all PCOS clinical signs, 4 phenotypes emerged. Phenotype A is characterized as having all diagnostic features of the syndrome. Phenotype B is considered to be original NIH definition of PCOS in women who have chronic anovulation and hyperandrogenism, but without requirement of polycystic ovaries on ultrasound. Phenotype C represents women who have regular ovulatory cycles but with hyperandrogenism and polycystic ovaries, and phenotype D represents normal androgenic women with irregular cycles and polycystic ovaries. Although initially we thought that clinical work with PCOS could be much more easier, we early saw that things are much more complicated now. A lot of studies showed that phenotypes differ by anthropometric, hormonal, and metabolic characteristics. All those differences lead to different risk for cardiometabolic complications. So, what do we know about PCOS phenotypes? When making a diagnosis of PCOS, establishing the PCOS phenotype is particularly important because phenotypes A and B are believed to be associated with severe metabolic alterations, while phenotypes C and D are considered to be mild forms of PCOS with little or no metabolic disturbances and with no need for follow-up for type 2 diabetes or CVD risks. However, there are still only a few comparable studies because heterogeneous results are consequence of ethnic variations, large differences in methodology between studies, and possible transition from one phenotype to the other. There are still no large longitudinal studies as well. So what about prevalence of different phenotypes? As you can see, the most prevalent phenotype in the majority of studies is phenotype A, especially in the European population. At the same time, phenotype D has the lowest prevalence. However, in Chinese and Indian population, the prevalence of phenotype A and D is usually similar. Obesity is an important factor for all hormonal and metabolic disturbances. In the majority of studies, hyperandrogenic phenotypes were found to be more obese than controls and phenotype D, but as you can see, there are still a lot of studies which found no differences between obesity prevalence among phenotypes. As with obesity, studies have shown similar results for insulin resistance. In the majority of studies, hyperandrogenic phenotypes were more insulin resistant. However, when we talk about phenotype D, results are heterogeneous. In comparison to healthy women, roughly half of the studies showed no differences, and the other half showed that phenotype D is more insulin resistant than controls. The analysis of the largest PCOS population studied so far by Carmina and co-workers in 2019 have shown that prediabetes is more common in hyperandrogenic phenotypes, especially in the phenotype B, compared to controls and phenotype D. Again, in comparison to healthy controls and phenotype D, hyperandrogenic phenotypes usually have worse lipid profile. However, some studies have shown that phenotype D could also have an unfavorable lipid profile. Usually, lipid profile in PCOS shows low HDL and high LDL concentrations, especially among European population. This was also in the study of Carmina and co-workers. However, in the USA, high concentration of triglycerides is usually found. In this large study, for example, it was found only in 3% of women with phenotypes A and C. Although each PCOS study analyzes some of the metabolic disturbances, there are few studies that analyzed metabolic syndrome prevalence. The comparison of studies is hard because every study uses different metabolic syndrome criteria. Also, the comparison of studies is additionally hard because not all studies have a control group, and the choice of control group is sometimes questionable, as you can see in this study from 2015. Here, the prevalence between phenotype A of PCOS and control group was the same. However, in the majority of studies, hyperandrogenic phenotypes, especially phenotype B, and after that phenotypes A and C, have the highest prevalence of metabolic syndrome. And in conclusion, phenotypes A and B are the most metabolically affected, but phenotype B has the most significant metabolic alterations. The highest prevalence of obesity, metabolic syndrome, altered glucose tolerance, and lipid alterations. Phenotypes C and D represent mild phenotypes of the PCOS syndrome with only minor or no metabolic alterations. However, women with phenotype C, although having normal menstruation and ovulatory cycles, exhibit important metabolic profiles which may place them at risk for developing type 2 diabetes and cardiovascular diseases. Women with phenotype D usually have no metabolic abnormalities. Thank you very much.